Hello everyone. Thank you so much for the response to my first video. Today I'm going to talk about being a patient advocate for yourself or for a loved one. Very important. I feel like for those of you who have commented on the first video, you mentioned that being an advocate was so important to you, that it really meant a lot to you, that I shared about that. So that's what this video is going to be all about. I'm going to give you two scenarios where my wife and I had to be our own advocate. Some serious situations, and we'll get into that. And then I want to talk a little bit about why I think it's such a need for that today. What's changed in medicine since I first started practicing 35 years ago to now? What's changed in medicine that really needs for the patient to be their own advocate? So just to give you a little bit more on the introduction, I'll put a link to my first video at the end of this one. But I spoke a little bit about having to suggest medications for myself. Really, even the first, when I went to that neuromuscular specialist back in August, I had to suggest the EMG and nerve conduction tests. She was a little reluctant to do it. And I said, I really think it'll be helpful. And sure enough, the results were terrible. And we were able to see that I had the, sensory motor polyneuropathy. So, and then the other thing is, I started my IVIG this week, and my next follow-up with the neurologist is September 10th. And I said to them, that's ridiculous. I'm getting these treatments every 4 weeks. This was the first one this week. I couldn't possibly go until September 10th to be reevaluated. And I got a call from them a couple of weeks later, thinking, oh, okay, I'm on the waiting list. I can get something a little sooner. But no, it was to change my in-person visit to a virtual visit, which is, as you can imagine, even harder to evaluate a neuromuscular patient. So that's it on the introduction. Now let's get into the first case scenario that my wife was involved in. Okay, so back in June of 22, my wife and I were at Disney Resort, actually, by the pool. And my wife went to turn around to head towards the food court, and there was a lounge chair right in front of her that she didn't see. So she stopped not to trip over the lounge chair and fall into the poor person who was laying in the lounge chair, and put her left leg out straight and kept herself from falling, but felt a pain in the back of her thigh. Didn't think much of it, but she was in excruciating pain. By the time I had gotten there later on to meet her by the pool, she said she didn't want to go to the doctor. She was okay. It hurt, but, she was going to be all right. Well, a couple of days later, it was still very bad. And we made an appointment with the orthopedist. As we get to the orthopedist, he examines her and says, well, you've likely torn one of the three heads of the biceps where it attaches to your pelvis and to the ischial tuberosity, actually. So we're going to do an MRI just to see, but generally it's just some physical therapy and rest and whatnot, and it usually heals on its own, but let's just make sure that's all it is. Well, we do the MRI, we're in the office the next day for the results, and he says, lo and behold, you've ruptured all three of those muscles, those tendons of the biceps. Now, this is a much more serious problem. You're going to have surgery for it. The very next day, we were in the surgeon's office. So that's how serious it is, because what can happen is those muscles, once they're torn off the bone, can start to retract. And if there is a decent gap, that's not going to heal again. So you're always going to limp. You're always going to be in pain. You risk getting some sciatica because the sciatic nerve runs through that. So you need to have the surgery done. Well, she gets the surgery done. All goes well. The first week, she was having some pain and swelling, and the doctor was a little concerned that it might be a blood clot because, one, that area for surgery is a very high risk of blood clot. And two, your leg is in a brace and you're not moving. You're not walking on it. You're basically sitting the whole time. I can't put any weight on that foot whatsoever. So she's in a walker, using a walker and hopping, with the walker, which was also very difficult on her hands due to her autoimmune disease. Well, that turned out to be no clot, so that was good. Now we're about 5 weeks post-op, 4 or 5 weeks post-op, and we're in the office on a Friday morning, and we're telling the doctor, hey, she's got a lot of swelling, and again, some pain in the calf, and we're worried about it being a clot again. And he absolutely assures us, no, perfectly normal, everything looks great. Later on that Friday, that night, she just starts developing some back pain. Now, she gets back pain occasionally, especially when she's sleeping wrong. And because of that huge brace across her entire leg, she's sleeping, in a weird position. And we're just blaming the back pain on that. Well, we go to bed Saturday night, and I notice she's having some shortness of breath. Not enough to concern her, but enough that I'm concerned, and I'm staying awake and watching her breathe. And I see the breaths are getting more and more shallow. I wake her up about 2 a.m. I said, that's it. We're going to the hospital. I'm not taking a chance. We go in. We say to the emergency room doctor, we're here to rule out a PE, a pulmonary embolism. And sure enough, he came back with the test and he said, unfortunately, you're right. There is a pulmonary embolism there. And she gets admitted to the hospital. She turns out to be there for a full week. Well, about 5 days in, she starts to develop some AFib and a rapid heart rate, which is very dangerous with a pulmonary embolism. They do a chest x-ray. She's got a little bit of a fever. She's got some fluid on her lungs, so she has pneumonia. So they want to give her an antibiotic. It's about 10 o'clock at night, so the doctor's not in there. So the nurse goes and calls the doctor and comes back and says, okay, the doctor wants to put you on Levaquin. My wife and I just stared at each other like, no way. And the nurse picked up on it and said, okay, what do you think is wrong with Levaquin? And what type of medicine are you in? And we said, well, we're both podiatrists, and Levaquin has a black box warning on it. All the fluoroquinolones do. I knew this from practice. The warning is spontaneous tendon rupture. Now, my wife just ruptured 3 of those tendons without even actually falling. There's no way she should be given Levaquin. Now, on one hand, I don't blame the doctor. The doctor that treats you in the hospital, the hospitalist, which I also hate, that's a whole topic for another video, should be a regular doctor. But the hospitalist is looking at her chart and seeing admitted for pulmonary embolism, has a fever, has pneumonia, is penicillin allergic, let's give her Levaquin. Not realizing the initial reason for the PE, what caused the pulmonary embolism, was the rupture of the tendons. So sure enough, the nurse calls back the doctor, and the doctor says, oh yeah, absolutely not. We'll give her something else. And I think to myself, you have to be your own advocate. I think, what do you do if you don't have that knowledge of a black box warning of an antibiotic, and you just say, oh, okay. I can't even imagine what would happen if she had taken that Levaquin and possibly ruptured the tendons again. So thankfully that all worked out all right. But if you can't be your own patient advocate, talk to someone who is. Hopefully you have someone in the family that's a nurse or a doctor or a PA or some type of medical professional that you could reach out to. Or don't just take the one doctor's word for it. Talk to other doctors or other specialists. And then now I'm going to talk a little bit about why this is happening. Why, at least I feel this is happening in medicine here in the United States. Being your own advocate is more important than ever. When I first started practice as a podiatrist, back in 1989, we opened the practice. My wife opened the practice. I was doing my surgical residency at the time in the New York hospitals. We were in private practice. We were it. It was a small family-owned practice. My mother was our office manager. My wife and I were partners. She was a podiatrist as well. When my girls got old enough to work in the office, they did, either taking patients back into the rooms, answering phones for us, returning calls. And it was our practice. It was great. It was wonderful. We got to know our patients. Some of my patients may even be watching this now. Thank you for watching. I miss you guys. I miss the practice. It was like we really knew each other. We were like family. That's how I felt. The first time you came in as a patient, we got to know you. After that, you were just family. And it was really so nice. And what I realized is, if a new patient, I'll give you an example. A new patient calls my office, and we don't call back till the next day. Chances are they probably called another podiatrist and got an appointment somewhere else. And you think, well, it's just one patient. Well, let me explain to you what that one patient loss would mean. Let's say the average patient was coming in to see me every 2 months, so 6 times a year. And on average, the visit was, let's make the numbers round, $100, through their insurance. That's $600 in a year. If that happened just once every 5 weeks or so, just 10 times a year, you're looking at a loss of $6,000 for the practice. Now, you have to realize that $6,000 is directly out of my pocket as the doctor. How so? Well, my staff was going to get paid no matter what, no matter how many patients came in that year. The rent that I owed the landlord was going to get paid no matter how many patients I saw that year. So all my fixed costs were going to get paid no matter what. So whatever my income was going to be $6,000 less that year. But it's even more than that, because whenever I did see a new patient, chances are either their husband or wife then would become a patient later on, or they would recommend me to a friend, a neighbor, or another family member. So that one patient was a loss of thousands of dollars. So at least in my office, we had that policy was if we weren't in the office, that message would get transcribed, sent to my phone, and I would immediately have someone on my staff, whether it be, my mom or my daughters or one of the other staff members who are like family to me as well, call them back right away. I would call them and say, hey, do me a favor, call this new patient back. And that's how we operated. And what's going on now is a lot of these practices are being purchased by the big corporations. I know it's happening up in New York. I see it happening down here in Florida. And the doctors are on salary. And you could tell that because the doctors are working from 9 to 5. No Saturdays, Monday through Friday. And when I say 5, I mean they leave the office at 5. So they take the last patient at 4:30. That's unheard of. When I was in practice, you had to have at least one night a week, maybe 2 nights a week, and certainly a Saturday or every other Saturday. We did it where we were 1 or 2 nights a week and Saturday, every Saturday for a long time, and then eventually every other Saturday. But the doctors now, it's not that big a deal because they're going to get their salary no matter what. Sure, they have to see a certain number of patients, I'm sure, but it's not like losing a patient or two is going to cut into their annual salary. And I think that's it. I think that's really a problem right now. So, hopefully something will change with that. I don't know if it will, but in the meantime, go ahead and be that advocate for yourself. Okay, in this last scenario now, I'm going to give you, again, it was my wife. So she was given a new drug therapy for her autoimmune disease. It's called leflunomide. We had never heard of it before. It's a relatively new drug from what we understand. And after she had been taking it for about 4 weeks, 5 weeks, she had developed an allergy to it. She had, I should say she had broken out in a rash. So we didn't know what the rash was from, but eventually we figured out that was the only new drug that she had taken. So it was not only Labor Day weekend of 23, but that next day, Tuesday, was a hurricane alert day. Now, it turns out we didn't have any hurricane at all, but everything was closed down here because they were worried about a hurricane. So her rheumatologist, who had given her the leflunomide, the office was closed. We called and left them a message saying, hey, I think she's having an allergic reaction to this. Can you please give us a call as soon as you get into the office? Well, we couldn't wait any longer than 3 o'clock that Tuesday. We went to a freestanding emergency room. Well, this freestanding emergency room was just awful. They actually could not get an IV started on her. There was literally a PA and a tech, one on each arm at the same time, sticking her, trying to get her an IV started. And we realized she's a tough stick, but probably shouldn't have been doing it at the same time to begin with, and really should have been able to get an IV eventually. And it turns out they did not. They could not start an IV at all. So standard protocol for an allergic reaction is IV Benadryl, IV prednisone, and, you go on your way. You get, as long as there's no airway problems, and she didn't have any trouble breathing or anything like that. So I didn't have to give her, any epinephrine or anything like that. Well, we go home. She's doing okay, goes to work Wednesday, goes to work Thursday. Well, Thursday night, the itching is so intense that I have to take her to the emergency room at 2 o'clock in the morning. She can't take it. We get to the emergency room, we go to the hospital emergency room, and this time they can start an IV. So again, they do typical IV allergic reaction protocol and give her some Benadryl and some IV steroids. And at this point, we tell them, listen, we think it's the leflunomide that did it. And they say, okay, they don't think much of it. They discharge her. She's already doing better. The hives are coming down. And we go home. The very next night, it happens again, 2 o'clock in the morning, Friday night, 2 o'clock in the morning. And we go right back to that same emergency room, see that same doctor. Now, in the meantime, I had done some research that morning. And I looked up leflunomide. Like I said, we were unfamiliar with it. It turns out that leflunomide will stay in your system without any other treatment for 2.5 months. That's right, 2.5 months. The ER doctor should have looked this up when we told them the night before that this is the case. And it turns out that you need to give the patient something called cholestyramine. It's a powder that you drink 4 times a day, every 6 hours, for at least 2 weeks until it can leach out the drug that you're allergic to. They found that leflunomide is very dangerous in pregnant women. So if a woman gets pregnant while on that drug, they need to give the cholestyramine to get it out of her body as quickly as possible before it does damage to the baby. So that night, Friday night, I said to the doc, I said, please, I think she needs cholestyramine. And he said, well, let me call poison control and see what's going on. He comes back, sure enough, poison control says, make sure she gets cholestyramine. And he did. So we did that. Unfortunately, the next night, Saturday night, 2 o'clock in the morning, she's still in incredible pain. She's going to need that IV Benadryl and IV prednisone again just to help her calm down. We go there Saturday night. We see the same doc again. He gives her the IV Benadryl, the IV steroids again. And he says, this time I'm going to give her some lorazepam. That'll help her sleep, get through the night. We really just have to wait it out. And he was right about that. We just have to wait it out. Get enough days of cholestyramine in her to get out that leflunomide. In the meantime, this is almost a week later, and the rheumatologist still hasn't called back. Disgraceful. Absolutely disgraceful. So we go home. Sunday night, she takes the lorazepam. Wakes up Monday morning, her skin, as you can imagine now, this is a full week of this allergic reaction going on. Her skin is just in so much pain. She just wants to get into a cold shower and try to get some relief. Well, as she goes in the shower, she starts not feeling well, like she's going to vomit. And as you can imagine, it's probably from the lorazepam and the Benadryl combined. It's just too much, and she's so tired and so sick, she felt she's going to vomit. Help me back in bed. Help me back in bed. I grab her from the shower, and she starts walking with me, and all of a sudden, she just stops walking, and I can't move her. Honey, what's the matter? And I realize she is completely unconscious. And I can't hold her. She's wet, and I bring her down to the floor. Her legs go back in tailor position and falls backward, and here I am thinking, oh my gosh, she's going to tear her hamstrings again like she did a year and a half ago. I get her back up. I get her conscious. I get her head down to get the blood flow going back to her head. I call 911, and the ambulance comes, and we take her to the emergency room. Well, she gets admitted because she hit her head a little bit, not too bad on the shower door, so they want to do an MRI of that, make sure her head's okay. And they want to monitor her heart and see everything else is okay. Well, as she's admitted and the nurse is coming in, they have the cholestyramine scheduled to be given to her at the same time as her meds. Now, here's what cholestyramine does. It leaches out of your bloodstream any medication you've taken within 3 hours. So you're going to just give her medication and take it right out of her again. We were going around the clock for a week. If medication was at 9, cholestyramine was at noon medication at 3, cholestyramine at 6, medication at 9 p.m., cholestyramine at midnight. Because we didn't want to leach it out. We had to do that 2 or 3 times with the nurses until they finally talked to the doctors and put her on the right schedule. Here's the worst part of it all. She goes to get discharged the next day. The discharge doctor comes in. He's talking to her about her heart. And I'm saying, Doc, it wasn't really about her heart. She had the lorazepam. It mixed with the Benadryl. I really think that's what caused the weakness. Besides, she's so weak from having 7 days of an allergic reaction and what that does to your system. Well, he gives her the discharge orders and he gives her the list of medications she should be taking when she gets home. What do you think's on the list? Leflunomide. Are you kidding me? The drug that nearly killed her is on the list for her to take on her discharge orders. We were baffled. My wife gets a survey in the mail a couple of weeks later. How was your experience at the hospital? I'm so glad you asked. She filled it out. We're not one to give negative reviews, especially being in medicine, and especially when it's going to be about another doctor. But this is dangerous. This is life and death. So she fills out the survey, fills out the whole thing, tells her, we're doctors. It's a good thing we knew not to take this drug. She got a follow-up call a week later, which was very nice. She said, I want you to know we take this very seriously. Not just because you're a doctor, but we can appreciate your insight. I'm going to follow up with this and make sure that everything is taken care of. Well, about 2 weeks after that, we got another call from that same nurse. She says, hey, Dr. Slory, talking to my wife, you remember me? And she says, oh, yeah, absolutely. She goes, I want you to know that we had a meeting about that. And this is probably the second or third time this doctor has done this. And he's been fired. She says, oh, I didn't want that. She goes, no, it had to be so. And she said, the Advent Health Heart of Florida, where it happened here in Davenport, Florida, everybody told us, don't go there. Go to Celebration Advent Health. It's much better there. And the woman says, it's funny you should say that because I used to be at Celebration. And when I came here to Davenport, I said, I want to give us the same standard of care as people are receiving in Celebration. So I'm glad you gave me that feedback. And I'm glad I'm able to go forward with it. So here again, just mind-blowing. I appreciate you coming along. I'm going to put a link over here to the first video where it talks a little bit about advocacy and certainly about my health journey. I'm going to try to follow up my health journey as well as we go along. I hope you learned a little something today. And if there's anything I could do, leave a comment, let me know. But be your own patient advocate. Get someone to help you out. So very important in these times. Thanks for watching, and God bless.